You're listening to Med School Radio, bringing you the best in medicine. Welcome back to Med School Radio. This is Simon in Tokyo, listening to Notorious Big, Greatest Hits, Hypnotize. Anyway, today we're going to be looking at some more osmosis questions. Let's go for it. Let's see what we have. First one. A 12-year-old girl comes to the ER because of projectile vomiting for the past 5 days. Prior to these vomiting episodes, she was healthy and an avid feeder, and the parents noticed an abdominal bulge that moved from left to right during feedings. Physical examination shows no abnormalities with the exception of a body weight in the 15th percentile, 4.98 kilograms. She also has dry mucous membranes and a capillary refill of greater than 2 seconds. The child is afebrile but appears fussy. Ultrasound shows a thickened pyloric sphincter wall. Which of the following serum laboratory values is most likely elevated? First, bicarbonate. B, bilirubin. C, chloride. D, creatinine. Or E, potassium. And the answer is A, bicarbonate. Why is it bicarbonate? Let's look at the major takeaway. With recurrent vomiting of any etiology, such as infantile hypertrophic pyloric stenosis, the most likely electrolyte derangement is a hypokalemic metabolic alkalosis due to the persistent vomiting of HCl from the stomach. The loss of the hydrogen ions and elevated bicarbonate causes the alkalosis. Now the main explanation. Infantile hypertrophic pyloric stenosis, or IHPS, is often associated with peristaltic fluid wave and classically associated with an olive-shaped abdominal mass that is virtually diagnostic for pyloric stenosis. Children with hypertrophic pyloric stenosis often present dehydrated with a hypokalemic metabolic alkalosis secondary to protracted vomiting, and patients often require aggressive rehydration and electrolyte replacement. However, keep in mind that this would be the initial treatment, not the definitive treatment. Emesis is non-bilious because the obstruction is proximal to the common bile duct. Sonographic thickness of the pyloric muscle wall or a length of greater than 13 millimeters can confirm the diagnosis of infant hypertrophic pyloric stenosis. And the classical treatment for IHPS is Ramstead open, pyloromyotomy, and laparoscopic pyloromyotomy, which is also growing in popularity. So that's the answer to that question. If you thought it was bilirubin, remember that children with hypertrophic pyloric stenosis often present dehydrated with a hypochloremic metabolic acidosis secondary to protracted vomiting, and bilirubin concentrations would not be affected by this condition. What if you thought it was potassium? So again, this is not associated with potassium, and the same explanation given there. So moving on. Okay, I'm going next question. Next question is, a 2-year-old neonate born to a 29-year-old woman is yet to pass any meconium. The patient's abdomen looks bloated, and when a finger is inserted into the rectum, there is an explosive passage of a stool. There also appears to be gas accumulation in her abdomen. A barium enema test is ordered, and the results of which are shown below, which you can't see. Which of the following findings would most likely be seen on a colonic biopsy? A, foamy macrophages in the lamina propria, and B, inflammation of the mucosa. C, lack of enteric nervous system ganglia, or D, transmural ulcers. Another choice here, villus atrophy and crypt hyperplasia. Okay, I'm looking again. So what could it be? And the answer is C, lack of enteric nervous system ganglia. We're talking about Hirschsprung's disease, which results from a failure of the neural crest to fully migrate through the gut to form the enteric nervous system. The aganglionic distal most aspect of the colon causes the obstruction that leads to a failure to pass stool, resulting in megacolon in neonates and newborns. Hirschsprung's disease, also known as congenital aganglionosis. The X-ray images show congenital megacolon suggestive of Hirschsprung's disease, and the disease is caused by abnormal neural migration from the mouth to the anus during neural crest development. The migration of neurons to progressively populate the enteric nervous system, Meissner or Auerbach's plexuses, is regulated via growth and trophic factors. Mutations in these factors can cause premature cessation of neural migration, resulting in a distal segment lacking any enteric neurons. So the aganglionic segment, always starting from the internal anal sphincter and extending proximately for varying extents, remains constricted and prohibits the passage of stool. The colon proximal to this segment gets stretched and enlarged, leading to the megacolon that is seen in the image. Obtaining a biopsy of the distal segment can determine if any enteric neurons are present. If none are found, a diagnosis of Hirschsprung's disease can be made, and treatment is resection of the aganglionic segment. So that is the answer there for that one. So remember, it's a failure of the neural crest to fully migrate through the gut to form the enteric nervous system. So if the child is not passing any meconium, consider this as a possibility. Okay, next question. A 5 weeks old infant boy comes to the ER because of repeated projectile vomiting that occurs after feeding in the last 48 hours. The content of the vomiting is mainly undigested feeding without bile. The infant appears agitated and inconsolable. An abdominal ultrasound is performed and is shown below. So which of the following is the most likely diagnosis? A, acute appendicitis. B, bowel congenital malrotation. C, esophageal atresia. D, hypertrophic pyloric stenosis. Or E, intussusception. So I've been reading that if you really recognize the question stem points well, you don't need to have an image. So let's read that again. 5 weeks old infant comes to the ER, repeated projectile vomiting that occurs after feeding in the last 48 hours. The content of the vomiting is mainly undigested feeding without bile. So without bile is a clue there. The infant appears agitated and inconsolable. An abdominal ultrasound. Okay. So what is the answer here? It is hypertrophic pyloric stenosis. Why is it that? Hypertrophic pyloric stenosis typically presents in the first weeks of life and is characterized by obstructed passage of gastric content to the duodenum. Projectile vomiting after feeding is the main clinical feature and is associated with high risk of dehydration. Diagnosis is with an abdominal ultrasound. So we talked about this similarly in another question. A pyloric olive may be palpable in the epigastrium or right hypochondrium. So let's go on to the next question. And it is cold in this room. This is Tokyo, December 13th, 2017. I'm sitting here listening to tunes. Got a cup of coffee. Noisy neighbors upstairs. Reading MCQs from the GI system and osmosis. Listening to the notorious big greatest hits. Okay, next one. A 3-month-old infant boy is brought to the pediatrician by his parents after not passing any feces for several days. This has happened several times before, but has always resolved on its own. A barium study is done and shows rectosigmoid narrowing. It is suspected that this condition may have resulted from the failure of certain cells to migrate into the intestine during development. Which of the following parts of the intestinal wall should most likely be biopsied to confirm this hypothesis? A. Crypts of Lieberkühn. B. Lamina propria. C. Muscularis mucosae. D. Pear's patches. E. Submucosa. Boy, these questions always mess me up. I always forget the order of the setup. I just wrote that down yesterday. See if I can find it. I can't. Anyway, let's take a guess. Which parts of the intestinal wall should be biopsied? I got it right. Submucosa. This is Hirschsprung's disease. It is caused by the failure of the neural crest cell migration into the intestinal nerve plexuses, causing a functional blockage. The rectal submucosa can be biopsied for diagnosis. So remember, it is the submucosa that you want to biopsy for Hirschsprung's disease. Let's go on to the next question. A 20-month-old boy comes to the ER because of rectal bleeding and abdominal pain. The mother says that 3 days ago, he first had a small episode of rectal bleeding and that he did not show any signs of irritation or pain, and that he was acting normal during the day. However, today he was found gripping his abdomen and crying in pain. Abdominal examination shows generalized tenderness to palpation. An abdominal x-ray shows a gasless abdomen and mild intestinal dilatation. Which of the following conditions does the patient most likely have? A. Duodenal atresia. B. Gastrochesis. C. Meckel diverticulum. D. Omphalocele. E. Tracheoesophageal fistula. The choices B and D can be confusing, whether it is gastrochesis or omphalocele. And I've learned this a bunch of times. I keep forgetting what the difference is. So let's look at again this question stem. Gasless abdomen, rectal bleeding and abdominal pain. Does not sound like gastrochesis or omphalocele. Acting normal, gripping abdomen, crying in pain, generalized tenderness to palpation. 20 years old. So it is a tracheoesophageal fistula? I don't think so. A Meckel diverticulum? Could be. Duodenal atresia? I'm going to go with diverticulum. And the answer is, I got it right. Rule of twos applies to Meckel diverticulum, which occurs in about 2% of the population. It is about 2 inches long, is found about 2 feet from the ileocecal valve. 2% of patients develop a complication over their lifetime and has a male to female ratio of 2 to 1. Complications can include a volvulus or malrotation. So this boy has developed a complication from his Meckel diverticulum, a volvulus. Although the plain radiograph of the abdomen only shows gasless abdomen, I don't see any radiograph, and mild intestinal dilatation, patients with volvulus can even have a completely normal x-ray. Therefore, plain radiographs are not used to confirm the presence of a malrotation of volvulus. Oh, I see. It says an abdomen x-ray shows a gasless abdomen and mild intestinal dilatation. Okay. I wonder if you can hear the baby in the background upstairs. It's fun to study with a baby crying. Okay, so let's take a little bit of break.
However, I stay Gucci down to the socks. Rings and watch filled with rocks. And my jam knocked in your Mitsubishi. Girls pee-pee when they see me. Navajos creep me and they teepee. As I lay down laws like Island Coppin. Stop it. If you think they're gonna make a profit, don't see my ones, don't see my guns. Get it? Now tell your friends, Papa hit it, then split it in two. As I flow with the Junior Mafia, I don't know what the hell's stopping ya. I'm clocking ya. Versace shade watching ya. Once the grin, I'm in game begin. First I talk about how I dress this and diamond necklaces, stretch Lexuses, the sex is just immaculate from the back.
Okay, we'll do one more, which is a little bit challenging, but listen in, maybe you'll get it right. A 4-week-old boy comes to the ER because of continuous postprandial non-bilious vomiting. He has continued to lose weight since birth and has become increasingly lethargic. His mother denies any complications with pregnancy or birth and denies any recent sick contacts. His temperature is 37 degrees. Pulse is 130, respirations are 35, and blood pressure 70/45. This is a 4-week-old boy. The child is lethargic with dry mucous membranes and a sunken anterior fontanelle. A palpable mass is felt in the epigastric region, and a succussion splash is heard on auscultation of the abdomen. Which of the following metabolic imbalances is most likely found in his laboratory results? So I'm going to tell you that this is metabolic imbalance is seen in patients with pyloric stenosis, and it is a hypochloremic, hypokalemic metabolic alkalosis. Continuous non-bilious projectile vomiting, particularly with an olive-shaped mass found in the right upper quadrant or epigastric area, should lead you to think of pyloric stenosis. So I'll give you the numbers. I don't know if you're going to be able to pick it out. I don't think I could. But I'll give you 5 choices. The first one, you have to find out what his most likely laboratory results are for this pyloric stenosis. A, pH of 7.3, bicarbonate 18, chloride 113, potassium 4.2. B, pH of 7.4, bicarbonate 24, chloride 100, potassium 4. C, pH 7.55, bicarbonate 17, chloride 92, potassium 3. D, pH of 7.6, bicarbonate 32, chloride 88, potassium 3.2. Or E, pH 7.7, bicarbonate 36, chloride 103, or potassium 3.7. I guess wrong. The correct answer is D, pH of 7.6, bicarbonate 32, chloride of 88, and potassium of 3.2. This patient has pyloric stenosis. Pyloric stenosis is due to hypertrophy of the pyloric sphincter. This presents the passage of GI contents from the stomach to the duodenum, and it commonly presents in the first month of life, but can present as late as 6 months. Commonly, you will hear a succussion splash on auscultation of the stomach, which is due to stomach contents hitting the closed pylorus. And patients can also be characterized by an olive sign, which is palpable mass about the size of an olive in the epigastric region. This is the hypertrophied pylorus. So what to remember here? Patients with pyloric stenosis will commonly be characterized by hypokalemic metabolic alkalosis due to hydrogen, chloride, and potassium loss in the vomit, as well as an induction of a contraction alkalosis due to severe dehydration. And lastly, the decreased plasma volume will activate the renin-angiotensin-aldosterone system, which will lead to continued potassium loss and bicarbonate reclamation. If the patient was a newborn or in general less than 1 week old, also consider duodenal atresia and look for bilious vomiting. Okay, well, thanks for tuning in. Osmosis has got a lot more questions. A lot more questions in this section. 46, actually, but I just went through 6. And thanks for hanging with Simon in Tokyo. Listening to Notorious Big. Greatest hits. Oh my god, the stuff that's said in this. Didn't realize. Big. Thanks for the music. Okay, tune in next time. We're going to do some more MCQs.